Good morning, students. Today we will discuss anesthesia management of patient with anterior mediastinal mass. The patients with anterior mediastinal mass are very challenging. Why it is challenging? Because it can cause major airway and cardiovascular collapse under the general anesthesia, which can be very fatal. The patients who are having symptoms or who are symptomatic or have compression of the vital structures on CT scans are at higher risk. The diagnostic criteria, or they may be posted for diagnostic procedures. The diagnostic procedures should be undertaken under local anesthesia. Careful preoperative assessment of such patients should be done, and it should be discussed with surgeon. Meticulous planning is required, and proper preparation should be there for to avoid possible perioperative complications. These complications are related to compression of major airways and vascular structures. This is the key for successful management. We should consider awake fiber optic intubation, and we should maintain spontaneous ventilation. Intubation should be distal to the airway compression, and there should be immediate availability of rigid bronchoscopy. It is very important. We should keep rigid bronchoscopy ready. What precautions were taken to avoid mask effects? Number one, we should do fiber optic intubation. Then, proper pre anesthetic evaluation should be done. Clinical examination should be done. We should look for signs of air obstruction, air obstruction, hoarseness of voice, breathlessness, cough, and cyanosis. We should assess the functional capacity of the patient. Stridor in supine for anterior mediastinal mass is a risky sign. It is challenging if there is a stridor in supine position. What investigation we should do? We must do X-ray chest, neck, AP and lateral. We must do CT MRI, spirometry, bronchoscopy. Cardiac evaluation should be done. It includes 2D echo, ECG, TEE. Then, for induction of general anesthesia, awake fiber optic intubation should be done. We can have double lumen tube or bronchial blockers should be kept. Intraoperative monitoring. Invasive monitoring should be there. We should monitor CVP, arterial line, pulmonary artery catheter. There are surgery related complications like hemodynamic instability. Post operative extubation, weaning should be done. We should observe for tracheomalacia, and we must do leak test, and then we should plan the post operative extubation. Post operative analgesia. There are different methods. Number one, thoracic epidural, it is a gold standard. Next is thoracic paravertebral block, intercostal block, erector spiny plane block. Thoracic epidural, you know. The intercostal block is equally effective like other block, that is thoracic epidural, paravertebral, ESP for postoperative analgesia. Intercostal nerve block includes inclusive when comparing with the paravertebral thoracic epidural anesthesia. Contraindications are local infection, side effect, local anesthesia, systemic toxicity. Both ERAS and European Society of Thoracic Surgeon recommend thoracic paravertebral block or intercostal nerve block for thoracic surgery as a part of ERAS protocol. Thoracic paravertebral block. Injecting drug In thoracic paraorbital space, it aims spinal and sympathetic nerves to create ipsilateral somatic and sympathetic block. It is performed to obtain regional anesthesia and analgesia for thoracic surgery. It is an alternative to thoracic epidural. It lowers the rate of perioperative ileus. That much precaution we should take. Thank you.